African alternative practices for eye diseases. So in this talk, I want to discuss about 12 diseases or clinical scenarios that are treated slightly differently at Tenwek. This may be due to resource limitations or diagnostic testing limitations. So let's get started. The first is quick and easy because we've already discussed it. The majority of cataract surgeries done in the developing world are done using the M6 technique. The preferred surgical technique in the developing world is manual small incision cataract surgery. And the reasons why: it's affordable, it's reproducible, and it's efficient. Although we are using phacoemulsification at Tenwek, manual small incision across the developing world is still the preferred technique. Let's move on. The next disease is diabetic macular edema. We know from protocols I and T that intravitreal anti-VEGF injections are superior to traditional focal laser for central involving DME. But here is the problem. Look at the cost of these agents in Kenya. Avastin is $55, ranibizumab $350, and aflibercept is $400. And although this is much cheaper than in the U.S., it's still quite expensive when the average daily wage of a Kenyan is $4 to $5 a day. So at Tenwek, we try to use the data from the protocols I and T, but we recognize the average Kenyan cannot afford monthly injections. Typically, we would use an anti-VEGF agent first, followed by focal grid laser 1 month later. And this is just one patient followed over 2 years. You can see the macular edema and heart exudate in the upper left picture, and after focal grid laser, slowly both of these have resolved over 2 years. Believe it or not, laser still works, and it can be combined with anti-VEGF treatment for effective treatments in a resource-limited environment. The next broad condition is uveitis. Let me just say right now that I have really appreciated the thoughts and comments by Dr. J.P. Dunn during the weekly chief rounds. We at Tenwek have learned a lot and try to implement the best uveitic practices at Tenwek. We all know the etiologies of uveitis can be quite broad. Uveitis is often categorized according to the location of inflammation, which also helps to direct laboratory workup. But in a resource-limited environment, we are limited on the labs available to us. So we rely on a targeted history with this big question in mind. Is this infectious or not? Our standard uveitis workup includes sedimentation rate, VDRL, HIV, chest X-ray, and sometimes gene expert, which is a sputum test for tuberculosis. If infectious, then we treat the infection. If not, then we turn to steroids or other suppressive agents like methotrexate. Sometimes, if the history or exam really makes us suspicious of TB, then we will treat presumptively for tuberculosis. Pediatric cataract. So I mentioned pediatric cataract in my previous lecture as being the most common pediatric eye surgery that we do besides trauma. In our setting, the most common causes of pediatric cataracts are inherited or traumatic cataracts. And we use a clear corneal approach, a continuous curvilinear capsulorhexis, and finish by doing a primary posterior capsulotomy through a pre-placed trocar cannula at the end of the case. Now, there are a lot of different practices regarding intraocular lens choice in children. Often in the U.S., if the child is less than a year old, they are left aphakic and correction is done with a contact lens or aphakic spectacles. And then, if greater than a year old, the child is left hyperopic as to aim towards emmetropia as a teenager. But at Tenwek, we follow a slightly different practice. First, if bilateral cataracts are present, we do both surgeries consecutively to minimize repeated anesthetic risk. As mentioned, we do a posterior capsulotomy using a retractor at the end of the case. And if possible, we never leave the patient aphakic despite the age. And that's because contact lenses are not an option, and many patients will not commit to having their child wear aphakic spectacles. So we consider the social situation and the ability to follow up. And if follow-up is expected to be poor, we aim more towards emmetropia with our IOL choice, hopefully to get the child through the age of amblyopic risk, knowing they will be myopic later in life. Allergic conjunctivitis. Well, vernal allergic conjunctivitis is very common in equatorial Africa and often leads to visual disability. Our first-line treatment is using a mast cell stabilizer or antihistamine and lubricating drops. For more moderate or severe cases, we add topical steroids or even supratarsal Kenalog. But patients here are at great risk of steroid-induced glaucoma because they have access to steroid drops at any local chemist without prescriptions. This is a picture of an 18-year-old patient that had been using steroid drops since the age of 7 to self-medicate her allergies, and she presented with pain in the right eye and a pressure of 55 and a pressure of 15 in the left eye. There were PSC cataracts developing, and as you can see, cupping of the right optic disc secondary to her chronic steroid use. So educating patients about the dangers of steroids is extremely important here. And what about cross-linking for keratoconus? Keratoconus is very common in Kenya, in Africa, and is secondary to the allergies and the eye rubbing. We often see advanced keratoconus in very young patients. So our protocol for offering cross-linking to patients is as follows. We first demonstrate progression, if possible, and we are treating corneas as thin as 360 microns with hypotonic riboflavin. We remove the epithelium, we use the riboflavin, and then we follow it with administration of UV light using a 10 milliwatt light for 9 minutes. This patient had a corneal thickness of 360 microns before cross-linking, and as is demonstrated in this post-op OCT, the treatment depth here is about 306 microns. So why treat cornea so thin when most studies don't recommend treating if the thickness is less than 450 microns? Well, all of these advanced keratoconus patients will progress to needing a PK if we are not able to halt the progression of disease. And in our environment, tissue is very limited. It's only what we can get donated from the West. And the third reason is that PK failure rate is much higher in children. So if we can halt the disease progression, even in these advanced keratoconus patients, we can delay the need for a transplantation for many years. What about ROP in Africa? Well, the incidence in general is lower because survival of premature babies is lower. At Tenwek, our protocol is to screen babies less than 1,500 grams who have been alive for 4 weeks. On average, the first 10 years of my time here at Tenwek, we were only treating 12 to 15 babies a year. But since 2017, we've been treating 20 to 25 babies a year. And I asked the question, why the increase? And in discussion with the neonatologist, or our pediatrician here, he said, for sure, it's because of surfactant. Surfactant has led to increased survival, which means an increased incidence of ROP. We typically do screening at the bedside of at-risk babies about once a week in our NICU. There's been a great initiative countrywide to do screening of at-risk premature infants. Prior to 2016, there was almost no screening here in Kenya, even in the national hospitals. Most hospitals do not have access to laser for treatment, but Avastin is readily available and affordable. So up until 2015, even here at Tenwek, we were using PRP laser treatment to treat all babies with type 1 ROP. But since 2016, we've been using almost exclusively bevacizumab. What about glaucoma treatments at Tenwek. Let me make a couple comments about this. I mentioned before that we use medical treatments, ciliary body destructive procedures, and surgeries to treat glaucoma. We also use shunts. Shunts have not been readily available in the country, but we've been benefactors of the generosity of New World Medical, who has kept us supplied with Ahmed glaucoma valves. But there's one difference in our technique of covering the shunt tube, and that's that we typically use the patient's own sclera to cover the tube by making a large scleral flap, since pseudoplast is not available. This works very well in our resource-limited environment. In more recent years, we've had access to glycerin-preserved cornea tissue, which can also be used. What about the topic of immediate sequential bilateral eye surgery? Typically, this refers to cataract surgery, but can include others. The advantages is that you minimize repeated anesthetic risk and reduce follow-up visits, but the disadvantages are the potential risk of bilateral endophthalmitis, corneal edema, and anisometropia, since the second eye IOL choice cannot be adjusted after the first eye surgery. Well, at Tenwek, we will offer bilateral surgery when follow-up is going to be problematic. And as mentioned in pediatric surgery, we do this to minimize anesthetic risk. In bilateral macular hole surgery, we do this to minimize the time required for face-down positioning. This is a common presentation of a child with bilateral cataracts. For bilateral cataract surgery in adults, we perform bilateral retrobulbar blocks prior to having the patient lie down on the operating table. This is the Tenwek version of a Honan balloon. And I showed this picture previously, but this patient had bilateral macular holes in consecutive sequential surgery. You can see 1 week post-op that there was hole closure on the left, but the larger macular hole on the right is still open. And the time required for face-down positioning is minimized when both eyes are operated on sequentially. What about the topic of nurse-administered intravitreal injections? I know this is a controversial topic, and I don't think it's being practiced anywhere in the U.S., and I fully understand the reasons why, but it is being done in other countries, including the U.K. This review of studies done in the U.K. of nurse-administered intravitreal injections demonstrated similar rates of endophthalmitis when compared to physicians. And with the advent of injection clinics, there was decreased wait time for patients and greater access of patients needing to see a retina specialist for other problems. Our clinics are busy, and so we do utilize some of our skilled nurses to give intravitreal injections. Only nurses that are trained by us can participate. The physician is always immediately available if there's a concern before or after the injection, and we have found no increase in complications. Now, what about the topic of anesthesia for eye surgery? Common anesthetic practices in the U.S. include topical or intracameral, peribulbar, retrobulbar, and general anesthesia. At Tenwek, we use almost exclusively retrobulbar blocks for all eye surgeries. And our protocol is that retrobulbar is used for elective surgeries because this is preferred when there's a language barrier. It eliminates pain and motility during surgery, provides extended pain control, and is preferred when training cases where procedures take longer. And again, here's our makeshift Honan balloon. That's simply a super pinky ball purchased at Walmart and an elastic strap. Similar to our intravitreal injections, the majority of retrobulbar injections are given by our trained nurses. They are highly experienced and they do a high volume of injections. This enables us to have a more efficiently run operating room. And the nurses understand the potential complications, including globe penetration and respiratory depression. Maybe even more controversial is the fact that we use retrobulbar blocks even in ruptured globe cases. In my experience, in our environment, the greatest risk to the patient comes with administration of general anesthesia. So if we can perform safe, effective eye surgery without it, that's what we do. And the final case I'll mention is when patients present with both dementia and cataracts. Our observation is that impaired vision compounds the anxiety and struggles that a patient with dementia has. This article in the British Journal of Ophthalmology finds that visual impairment due to cataract may stress impaired intentional mechanisms, and cataract extraction may improve cognitive performance in some patients with early cognitive impairment. So here's a patient with dementia and bilateral cataracts. She had just undergone M6 surgery of the left eye, but her left eye is patched and the right eye still has a dense cataract. She's confused and very upset. Here's the same patient one day after we removed the patch from her left eye. She is reasonable and carrying on very normal conversation with our staff. So in summary, the practice of evidence-based medicine is critical, even in the global setting, but sometimes alternative techniques and protocols have to be established because of limited resources. Thank you.